Good morning to our Asian friends and good evening to Dr. Daniel Nissman right here. We are so privileged to have you tonight, of course, in your area. And good morning in our place for accepting our invitation to give a lecture in our mask ultrasound Zoom meeting. And we are so happy to have you. It's been a long time since we met in AIUM, maybe about 3 or 4 years ago that was. And I'm so grateful that we have that privilege. And today, I am so grateful also that you are here with us to join us in this Zoom meeting. Daniel Nissman has a very long list of accomplishments. His CV is really quite long, but let me just give a few highlights about himself. Daniel Nissman is a division chief of the MSK Imaging, and he's an associate professor of radiology of the University of Northern Carolina School of Medicine in the USA. And today he will talk about the foot and ankle ultrasonography, and interestingly, it only talks about the 5 most interesting pathologies. So we would like to welcome everyone to this meeting. And before we proceed, we will have a short prayer. Let us all bow our heads for prayer. Heavenly Father, as we begin, Lord, this meeting, we would like, Lord, to ask for your presence to be upon us. Guide us, and may we learn from the lecture of Dr. Daniel Nissman. And may this also educate us to be more careful and diligent in our examination of patients with foot and ankle abnormalities, and especially guide us as we treat our patients and be an effective medical practitioners for them. We ask, Lord, that thou will guide us today and keep us safe from any infection, from any harms and dangers. In Jesus' name we pray. Amen. So Dr. Daniel Nissman, welcome to our mask ultrasound Zoom meeting. It's now your time.
All right. Thank you, Jim, for that great introduction. I do remember it's been about 4 or 5, maybe even longer, that we met at AIUM. So let's see. We'll do that. This is a presentation that I gave at the AIUM this past year, which was all virtual, and I had to pre-record it in 20 minutes. We have a bit more time here, and that will allow me to embellish on some of the things that I couldn't really embellish on in the original presentation. So I've written a textbook, has nothing to do with foot and ankle ultrasound, unfortunately. So I will talk very briefly about some technical factors that are relevant to the foot and ankle. These are probably, if you know anything about ultrasound, you probably know some of this already. And then I will talk about the top 5-ish most interesting diagnoses, because it's impossible to talk about just 5 interesting pathologies. So in terms of the foot and ankle, it's unusual because there are a lot of nooks and crannies, such as around the malleoli. So using a small footprint linear transducer like you see here, you can see things like the peroneal tendons here and the very nice calcaneofibular ligament here, which you might not see quite as well with a linear. Now, when you're looking at something large like the Achilles tendon, here I'm in transverse, and you might say, well, that's you're only using a small proportion of the transducer length here, but when you go in long axis, and you'll see images of this later, you can see a lot more of the tendon that way. We always want to use a linear transducer because tendons and ligaments are highly ordered collagen structures, and you want to have the sound beam perpendicular to the collagen fibers, and you have the best chance of that with a linear transducer. With the curved transducer, like you might see for doing hip or abdominal work, all of those beams are at multiple different angles, so you're going to have a hard time imaging some of those collagen or structures like tendons and ligaments. All right, so anisotropy is a very important concept in ultrasound, especially for musculoskeletal ultrasound, in that the sound beam must be exactly perpendicular to the tendon or ligament, or signal loss occurs. So, and it can be off by as little as 2 to 5 degrees, which is not a lot. So down here on the lower left, we have the medial ankle, and I've labeled the tibialis posterior and the flexor digitorum longus tendons. Now, in some people, which they have a lot of fat, it may be difficult to exactly locate these tendons. So you can actually use anisotropy to your benefit by toggling the transducer off perpendicular, and you'll see that this that the signal from those tendons disappears essentially. So you can locate things this way when it may be difficult otherwise. Now, as the peroneal tendons travel distal to the lateral malleolus and come to the peroneal tubercle, the calcaneus, they are actually curving at slightly different rates. And so you can actually see the anisotropy here. I call this the winking tendons. We're going to see if I can, there we go. So I'm just toggling the transducer back and forth, and one comes into full view as the other one goes out of view, like that. All right. Okay, so we're going to talk about some pathologies now, and I'm going to focus on a fair amount of time on Achilles tendinosis and Achilles tears, because that is a big part of where ultrasound really shines. Then we're going to talk about inflammatory processes, tinosynovitis, synovitis, and bursitis. And then we're going to talk about the classic foot-related masses, plantar fibroma and Morton neuroma. But there are other important masses that we need to talk about as well. So you can see how we've already exceeded that 5 pathologies. Okay, so we need to understand the normal appearance of the Achilles tendon, maybe best seen here. It's a uniform thickness structure, which has this echotexture that we call fibrillar. So you can see these multiple linear hyperechoic lines in here, and those are supposedly represent those highly ordered collagen fibrils. So tendons normally should look like this and have uniform thickness. And then here, this is just a cross section. It doesn't have quite as iconic a look as the fibrillar pattern here, but you can think about it as lots of bright dots on a somewhat black background. Okay, so this picture over here, which I've taken from this journal here, it's really here just to illustrate the complex structure of the tendon. There are multiple different subunits that are collected together to create the whole structure. So some of the important things to think about here is that tendon is a dynamic tissue. So I've mentioned the collagen fibrils, but between the collagen fibrils is this non-collagenous matrix. And then there are a few tenocytes which help with regulation. Tendons are elastic, so they can stretch up to 4% of their resting length before they start developing micro tears, and then 8% of their resting length before macro tears, things that were probably more clinically relevant. And also, very importantly, just like bone, tendons are constantly remodeling. So immobilization of the tendon is actually a bad thing to do, because then the stimuli by which the tendon depends to continuously remodel itself go away. And also important, there are no blood vessels or nerves within the tendon substance. All right, so I'm going to gloss over this a little bit, but whenever the tendon is injured, it enters a very brief inflammatory phase. So maybe 48 hours or 2 or 3 days worth where there might be some in-migration of inflammatory cells, and then there will be ingrowth of blood vessels. And then we go into what's known as the proliferative phase, which is on the order of weeks. That's characterized by collagen and extracellular matrix production. And then importantly, in this and all the remaining phases, there are no inflammatory cells. Then we enter a remodeling phase where those chaotically deposited collagen fibers was deposited. This is the phase where you realign all of the collagen and matrix into a functional unit. And then at the conclusion of the healing response, we have the neovessels that started to grow in the inflammatory phase recede from the tendon proper. All right, so let's talk about tendinosis. So there is non-insertional and insertional Achilles tendinosis. The non-insertional form is the most common. It occurs 4 to 6 centimeters proximal to the calcaneal insertion. And there are basically two explanations, which I think are just sort of intertwined. That region is a vascular watershed region, which means that there is a tenuous blood supply to that region. And then also, the Achilles tendon makes a 90-degree turn medially as it goes from the gastrocnemius and joins with the soleus aponeurosis and then proceeds distally to insert on the calcaneus. So when you're contracting your soleus and gastrocnemius muscles, you're actually, in a sense, wringing out the remaining blood in the tendon, much like when you have a wet towel and you're trying to get the water out. There's also an insertional form, which we can see here. This is calcaneus, and it's enlarged here. You see a lot of bony irregularity. Insertional Achilles tendinosis behaves like tendinosis elsewhere in the body in that it really occurs at an attachment site. So the things that you see there are enlargement and that bony irregularity, which represents sort of micro tears or cracks in the bone into which fluid it goes into. So the classic, this is just a classic enlargement mild tendinosis here. All right, so how do we get tendinosis? Well, it's repetitive interruption of the normal tendon healing response that after a certain amount of time enters a dysregulated healing state. And then it's unable to complete that 4-phase cycle that we discussed earlier. So the main association here is improper training and age. The weakened warrior is a classic patient who has this. There are some other associations, some genetics, diabetes, and fluoroquinolone use as well. All right, well, it's very nice. This is one of the few times where the histologic findings actually mirror the sonographic appearance, or vice versa, depending on your perspective. So in very early tendinosis, what you get is an increase in the amount of extracollagenous matrix, but the collagen fibrils are preserved. So this, we already saw this picture. You have enlargement, but you can see that those fibrils are more or less continuous through that region. And that's what we see here in the early mild sonographic appearance. Then as we progress along the spectrum, there's further enlargement. Then you start to get some fibril disruption. And that corresponds to focal areas of hypoechogenicity, like here, where we start to get some microscopic tearing or disruption of those collagen fibers. We also get ingrowth of vessels, which we see here. And then that corresponds to vascularity on Doppler. And then the final histologic stage, or the severe, what we would call severe tendinosis, is we get large-scale fibril disruption. We also get marked blood vessel and nerve ingrowth. And as you can see here, it's markedly thickened and hypoechoic. There's really complete disorganization of the fibrillar pattern. So, and that these basically mirror each other. So here just an example of neovascularity. So what we get here is ingrowth of blood vessels into the abnormal tendon due to chemotactic factors. And also with these aberrant vessels are abnormal nerves that grow in with it. And those nerves are the ones that are responsible for the pain. Now, it is important to note this vascularity is not related to inflammation. And in fact, we should be referring to this as tendinosis and not tendinitis. All right, there is diffuse tendinosis, which is basically all of the above, so insertional and non-insertional together. One thing that you do see with insertional tendinosis is intratendinous ossification. That seems to be unique to the insertional form of Achilles tendinosis. And it's related to membranous ossification like you see in development. Here is, again, at that abnormal and a normal comparison here. And then here's just the cross-section of that severe tendinosis that we showed before and a normal comparison. Okay, non-insertional Achilles tears. So these are actually quite common. Most occur in tendons with underlying tendinosis. If you have an Achilles tear that does not have tendinosis, it's usually due to a laceration from, a power tool or, a knife or something like that. Now, the reason that we want to think about imaging is that complete loss of ankle plantar flexion is not a reliable finding for a full thickness tear. In fact, you can still get some limited plantar flexion with intact medial and lateral ankle tendons. So imaging is important for documentation and treatment planning. We're going to focus on full thickness tears here. So one thing that I like to do is a panoramic view. So you have the transducer positioned along the long axis of the tendon, and then you just, depending on the manufacturer, they have different names for it, but you basically slide it along. I usually start here and slide it proximal, and then it stitches the images together, and so you can get these nice panoramic views of the tears. So here's a nice tear in the setting of diffuse tendinosis, another tear in the setting of more diffuse tendinosis as well. So a primary sign of tear is you see the actual gap. In this case, you can see the tendon coming to a point here. Maybe there's just a line. Here's fat filling that gap here. This one is maybe a little bit more difficult to figure out. A very useful effect is so-called edge shadowing, which I've marked here with these asterisks. And that indicates the end of the tendon. So at least maybe here there's one tendon end right here. I think that the other one is right there. So let's say you're not sure whether there's a full thickness tear or not. You can use dynamic imaging. And if the whole tendon moves together, it's a partial tear. And if it doesn't move together, then it's a full thickness tear. So one of the important things to document is the status of the plantaris tendon. It is important to note because it can be used to augment a repair. So here we're at 3 levels: proximal, aphotear, and distal. You can see there's no identifiable tendon substance here. And then we have this thickened structure right here, and that represents a hypertrophied intact plantaris tendon. All right, so dynamic imaging is important even if you already know that there's a full thickness tear, because if you can get the tendon ends to touch each other during plantar flexion, then that improves the prognosis of the tear. So here's one where we have the no gap in plantar flexion. You can also see that edge shadowing right there. And then here's one where there's a persistent gap. right. Okay, so how do we treat these? So you can actually treat these conservatively, even if there is a persistent gap. There's lots of literature out there saying that some of these people do well with conservative treatment. Obviously, a lot depends on the physical requirements of the person's job or living situation. So a lot of people, obviously, if you're an athlete or somebody who's a manual laborer, you're probably going to end up getting surgery. It makes sense that there would be a lower rate of re-rupture, and obviously if you can incorporate an intact plantaris tendon, that improves things. Now there are some soft tissue complications that come with this. The surgical option is that you can get infection, and because it's basically skin lying right on top of the tendon, you can disrupt that blood supply and get skin necrosis, although even those complications are relatively uncommon. And this is just an image of a repaired tendon where you see shadows from some of the sutures that were used in this case. Okay, we're going to switch gears now. We're going to talk about inflammatory processes, particularly tenosynovitis, but then also synovitis and bursitis. All right, so tenosynovitis is inflammation of the tendon sheath, or any synovially lined structure can become inflamed and follows the same rules. Signs of tenosynovitis are thickening of the synovial lining, hyperemia, and effusion with debris. If you just have an effusion without any debris or any other signs, that is quite nonspecific, and you should entertain physiologic fluid as a possibility or other causes. In the shoulder, for example, if you have a bland effusion in the biceps sheath, you should think about a rotator cuff tear. Here are just two examples. Here's tibialis posterior tenosynovitis, large effusion, a large amount of Doppler signal, and a normal tendon. Here, around the peroneal tendons, it's not quite as crisp a looking image, but the tendons are normal. Lots of Doppler signal. There's a little effusion. Maybe this is debris, or maybe this is wall thickening. Here are just two more examples. Tibialis anterior tenosynovitis, relatively normal looking tendon here. A little bit further down, you have normal tendon, but then this either thickened sheath versus material within the sheath. We have hyperemia on Doppler, and this is just a contrast enhanced MRI showing that there is enhancement here. Actually, there's some additional enhancement around other tendons as well. Here's peroneus tendinosis and tenosynovitis, so they do travel together. Here we have peroneus longus and brevis. There's fluid in the sheath. Here we have very abnormal appearing tendons, slightly enlarged. So there's an element of tendinosis here for sure. Looks like there's sheath wall thickening. There's here again, we have an effusion. And then here's a MRI, again, showing enlarged abnormal appearing tendons, and then enhancement of the sheath. And then here's an example of chronic extensor digitorum longus tenosynovitis. Here we know it's the extensor digitorum longus that we're looking at because of the multiple constituents here. Large effusion, sheath wall thickening. I'm not sure you can see that there, but maybe you can see here that this hypoechoic rind represents the sheath wall. There is some, not a lot of enhancement or hyperemia here. And then here's a long axis view showing this area of narrowing. So there's an entity called stenosing tenosynovitis that can cause scarring of the sheath. But in this case, that is due to a retinaculum and not stenosing, due to stenosis. All right, looks like I am talking too slow. We'll speed it up here. So along the same lines, retrocalcaneal bursitis, same idea, thickening of the lining, hyperemia, and infusion with debris. Here is the same idea. There's fluid in the retrocalcaneal bursa, there's hyperemia, and then there's either wall thickening and or synovial hypertrophy and debris. Okay, synovitis, same idea. We can see it in a bunch of different places. Here is the first metatarsal phalangeal joint showing hyperemia and synovitis. Here is the MR showing contrast enhancement, very little fluid. This ended up being infected. And then here is a talar joint effusion due to gout. And then there's a little, just sort of like irregular echogenic line on the talar cartilage that has been described in association with hyperuricemia deposition. This is just an aside. Thrombophlebitis, another thing that commonly occurs in the calf and around the foot and ankle, a non-compressible hypoechoic structure here with lots of associated hyperemia consistent with septic thrombophlebitis in this case. All right, foot masses. We'll try to get this out in maybe 5 minutes or so. I hope that's okay. Okay, unique to the foot, plantar fibroma and Morton neuroma. Here's an example of a plantar fibroma centered in the plantar fascia. Here's a Morton neuroma. We're going to see a lot more of that. Metatarsal heads here. We're also going to mention the ganglion cyst, which is the most common mass-like lesion of the hands and feet. Here's one dorsal to the first MTP. And another mass that is common to both the hands and feet, a tenosynovial giant cell tumor. Okay, plantar fibroma, nodular mass, arises in the middle or distal third of the plantar fascia, central and medial cord, bilateral and 20 to 40%. Really, these need to be treated conservatively. If you do surgery on them, they can recur and then they will often invade the underlying musculature. You must document connection with the plantar fascia. They are discrete nodule, mixed echogenicity. They often have posterior acoustic enhancement, which is very interesting, given that how dense and fibrotic they are. And they have variable internal blood flow and mostly little to none. So here's a little bit of blood flow, almost no blood flow. Recently, some people described the so-called comb sign, which is linear bands of hyperechogenicity within the mass. I've only been able to find it personally in the transverse plane. So these are the long axis views as transverse. And it's thought to be to the development of fibrous septae in long-standing lesions. Okay, Morton neuroma, compressive neuropathy of the plantar digital nerve, located between the metatarsal heads due to repetitive microtrauma. You get pain, numbness, and paresthesias at or distal to the neuroma. The third, fourth metatarsal interspace is by far the most common because the nerves are larger there and there's the greatest amount of movement between the third and fourth metatarsals. So the ultrasound characteristics is a small hypoechoic mobile mass, and then there's Mulder's maneuver, where you squeeze the metatarsals together. And before there was ultrasound, Mulder described an audible click or a palpable click, and that's referred to as Mulder's sign. So here is an example of Mulder's maneuver, hopefully. You can see the neuroma there being pushed out from between the metatarsal heads there. Okay, ganglion cyst. Again, most common cystic mass of the hand and foot. It's a fluid-filled sac associated with joints, tendons, and ligaments. Generally asymptomatic, but they become symptomatic when they rub up on things, whether it's a neurovascular structure or maybe it causes rubbing of the foot or ankle on the shoe. These are just some examples. Second metatarsal shaft here, ganglion cyst. I think I have an MRI. No, I don't have that anymore. Okay, ultrasound characteristics, anechoic mass with thin rim, no internal vascularity, and it has posterior acoustic enhancement as well, which is that bright signal that you see posteriorly. Tenosynovial giant cell tumor. This is a benign soft tissue mass associated with the joint synovium or tendons, may be locally aggressive and needs to be excised. And it's a circumscribed mass that you see here. Heterogeneous hypoechoic echo texture, so it's not as uniform like in some of the other masses that we've seen. And it does have some internal vascularity. So we see that here and here. And on this MR, I don't know if you can see that, but there are erosive changes of the dorsal midfoot. And this is why these need to be excised, because they can be locally aggressive, even though they're not malignant lesions. Okay, summary. Anisotrophy is a potential pitfall, but can also be useful to help you find things. Noninsertional Achilles tendinosis is the model system for studying tendinosis, and the histology follows the ultrasonographic findings. Dynamic imaging of full thickness tears is important for prognosis. Tinosynovitis and synovitis and bursitis. The key findings are hyperemia and synovial thickening. Effusion alone is nonspecific. Foot masses. Plantar fibroma is a fibrous lesion associated with the plantar fascia. It is essential that you document that association with the plantar fascia. If it does not connect to the plantar fascia, it could still be a fibroma, but all kinds of other things need to be considered, including sarcoma. And then Morton neuroma, small plantar digital nerve fibroma, and then we use Mulder's maneuver and sign to help us make the diagnosis. And with that, I thank you for your attention, and I will entertain any questions if we still have time.
Thank you, Dr. Daniel. That was a very comprehensive and wonderful lecture. Thank you so much. I have a question.
Okay.
I will have to sort of the first question here. Is there a role for elastography when diagnosing, let's say, Achilles tendon, for that matter, where it is very common, maybe for sports or athletic patients when we assess them initially?
So, I mean, that's really still a research question. You know, I don't personally use elastography routinely. I actually, interestingly, I use it mainly when I am biopsying complex masses to figure out where the solid components are. I think that Ken Lee out of University of Wisconsin-Madison, he's been doing some great work looking at the use of elastography to study treatment and the response to treatment. But I don't think that it's useful for initial diagnosis, at least right now. I think we can use the grayscale findings and the dynamic imaging to help us with that. But, you know, I think that elastography as an additional modality will be someday down the road part of our usual toolbox for helping us solve difficult problems. Primarily, I think it's for treatment response, because sometimes the repaired tendon, or even if it's just tendinosis and you haven't torn it, but you're doing treatment like eccentric lengthening and stuff like that, it may be useful to document return to normal function, whereas the grayscale may never return to normal.
I see. One other question is, some people are saying that if you have a 10 centimeter thickness of the Achilles tendon, that translates into a tear. Is that a correct statement, or?
Wait, say that again.
A 10 centimeter thickness of the Achilles tendon. There's this
10.
Yeah.
Are you sure? 10 centimeters? That's a very big tendon. So I'm not sure what you're asking.
Yeah, there's this study which says that in the absence of an actual tear and the measurement swells in the non-insertional part, 4 to 6 centimeters from the, I think that 10 millimeters, I would say.
Okay.
That's 4 to 6 centimeters from the insertion, and swelling is around 10 millimeters, then it translates into a tear. Is that a correct?
I don't know. I think you have to take every case on its own basis. We have a saying in radiology that the most dangerous thing is a radiologist with a ruler. So they can be numbers like that can be helpful, but I think that you have to just take each case on its own and look at it that way. I mean, you can have quite a bit of thickening and still have an intact functional tendon. Like I said, that first phase of tendinosis is proliferation of that extracellular matrix, but preservation of the collagen matrix. So in theory, you could have a lot of extracellular matrix and still have preservation of the collagen network. So I think you would have to do dynamic imaging, other things like that to confirm a tear. So I would not rely on a measurement per se.
I see. Okay, thank you very much.
Mm-hmm.
I don't know if there's other questions, but I have one more question. Okay, Jojo, go ahead. Dr. Franklin here.
Mm-hmm. Thank you for the excellent slides that you presented, Dr. Nissman. Appreciate it very much, sir. I hope you don't mind if I ask, what do you think would be the #1 most common nerve pathology you would see in this area?
Well, I personally see mostly nerve sheath tumors, and they usually end up in the tibial nerve. So whether it's above the ankle or in one of the branches. That's probably, in my experience, the most common thing. But I mean, a compressive neuropathy, like the Baxter neuropathy, which is compression of the inferior calcaneal nerve, probably by numbers is probably the most common pathology. But whether it's clinically relevant or not, that's debatable. So, I mean, in some people it's relevant, but not in most people, I don't think. So, what do you see as the most common nerve pathology?
Well, yeah, maybe the compression of the tibial nerve, I suppose, at the
tarsal tunnel. Yeah. We get a lot of requests for tarsal tunnel. I hardly ever see anything, so.
Right. Oh, you mean Dr. Nissman? There's no findings that could ultrasonographically could tell that it's a tarsal tunnel.
No, it's just that, a lot of times nerve pathology doesn't have an anatomic finding, I mean, it's, and that's the most frustrating thing about nerves in general, is that people are complaining they have symptoms, but you can't find an anatomical site of entrapment. Sometimes you have to do nerve hydrodissection and hope that there's some microscopic, band that's doing some compression that you can't see. But yeah, I mean, I think that nerve imaging is challenging, and requires a lot of work. I mean, not just ultrasound and maybe some diagnostic procedures like doing therapy or diagnostic blocks to see if that's the right nerve, and maybe doing nerve conduction studies. I mean, there are a lot of things that sometimes they're not specific enough, and you have to try a lot of things, unfortunately. So yeah, I'm actually doing some work with MRI neurography where we're trying to figure other ways out of diagnosing nerve pathology. But
thank you, Dr. Dan.
But yeah, so yeah, tarsal tunnel, probably the #1 spot where people ask you to look for a nerve problem, right. But I hardly ever find something. I mean, there are a lot of
I agree with you.
lesions, scar tissue. A lot of people have some kind of a release or something like that. That's the most common finding is scar tissue. But if they haven't had surgery, it's good luck. So.
Thank you very much, Dr. Nissman. Mm-hmm. Appreciate it.
Can we ask one more question, Dr. Daniel?
Sure.
Okay, when you see a retrocalcaneal bursitis with calcification, would you think about other issues that may be ongoing with the patient, like Haglund's disease or anything like that? Or it's just plainly That specific?
It depends. So, I mean, there are many reasons to have retrocalcaneal and even retroachilles bursitis. I mean, the most common one is friction. So whether it's due to Haglund's or just ill-fitting footwear, that's probably the most common. But inflammatory arthropathies can cause bursitis in that region. Rheumatoid arthritis, in fact, it's not common, but if it occurs there, that's a fairly specific sign, especially if you have an erosion along with it, then that's a fairly specific site for making the diagnosis or suggesting highly the diagnosis of rheumatoid arthritis. Calcium deposition, so you can have calcific bursitis, just like you can have calcific tendinitis. In theory, you can have that anywhere. I've never seen it in the around the foot and ankle, but that doesn't mean it can't be there. So if you find one, I want to see it. No.
Okay, there's one more question, Dr. Daniel here. This is from Dr. Pash. Dr. Pash, why don't you ask Dr. Daniel directly?
Hi, Dr. Daniel. Thank you so much for this lecture. I was just wondering, in cases of like nerve impingement or nerve pathology, is there such a thing as it's too early to view it in ultrasound? Is it better to wait for a few days whenever the patient has had some symptoms, or early on we catch any changes? Thank you so much.
That's a great question. I wish I had a great answer for you, but as I mentioned earlier with, I apologize, I forget your name, but who asked me what the most common nerve pathology is. You know, it's nerve imaging is incredibly challenging, even when the patient is symptomatic. So the one thing you get when they're symptomatic is you're pretty sure what the location is, but seeing actually something that you can point to on ultrasound is very difficult. It's not to say that you can't ever see it, but you know, the finding you'd look for is focal enlargement, hyperemia around the nerve, but both of those are quite uncommon to see. So I think that what you're often left with is doing a diagnostic anesthetic block just to see if that's the right distribution. And then if it is, then you can try a nerve hydrodissection or something like that.
And then maybe, doctor, using some power Doppler or color Doppler can also help, right? Yeah.
Right, exactly. That's when I say hyperemia, that's what I mean. So the signal on. Now, I should mention that Doppler is relatively insensitive for microvascular blood flow. So if it's present, it's helpful. But when it's not there, especially when you're thinking about inflammatory processes, it doesn't mean anything. It doesn't mean that there's no inflammation. There is some new technology coming down the pipeline called that. I think Siemens is calling it microvascular imaging or GE, or I can't remember who it is. Yes. That looks like it might be promising for looking at that really like end capillary blood flow that might be helpful for this kind of thing. So.
Thank you, doctor. Thank you.
You're welcome.
Well, thank you very much, Dr. Daniel. I was also wondering what word were you using? Are you using E10 or are you using EPEC?
I use the Siemens and the GE. I gave up a long time ago fighting with the powers that be about what machine I get. So I just kind of make the best with whatever I get. Although I am, after talking to Ken Lee at AIUM this past year, I'm pushing to get the new software version on the GE Logic 10. So
that's great.
Yeah, because they apparently have a new shear wave implementation, but they also have that microvascular blood flow thing. So that's I'm trying to get that.
Great, that's a very nice feature of that ultrasound. MPI, very good. Well, thank you, Dr. Daniel, for your wonderful time with us. And it's been a pleasure to have you, learning from you, and really getting those ideas that's kind of clearing our our minds of all those things. Nice to hear it from a radiologist like you. Jojo, you have last words?
Thank you very much, Dr. Nissman, for sharing your valuable time with us, and we sure learned a lot today. Thank you so much. We've heard a lot about you in your AIUM lectures, and we look forward to seeing more of those. Thank you, sir.
All right. Well, thank you for the kind words.
Looking forward to seeing you in person, Dr. Daniel.
Absolutely.
Yeah.
Hopefully in Orlando. Oh, yeah, no, I'm sorry.
Well,
San Diego.
San Diego. Yeah, that's right. San Diego, yeah.
Get ready for a long haul flights, though.
Yeah. I gotta start working up to it. So San Diego, then Hawaii.
Thank you very much, sir.
Thank you very much.
All right. Thank you. Nice to meet you all.
Thank you all. Thank you.